So third case, we'll start with showing some slides. It's a boy who is now 3 years old. He presented in the neonatal period with a very severe mitral regurg. It was a real bad valve with short chordae, short leaflets, leaking enormously. And so we asked the surgeon at the age of 2 months to do some surgery. He did a plasty of the ring and patch augmentation of the cusps. And the initial result was pretty good. However, as you can expect, something is going to happen while growing, and so that was in this case progressive stenosis. Next slide. Here you see the pictures on the right side with the mitral valve, which obviously doesn't look good. The annulus is rather small. There's a stenosis rather distal, and on the left side you see that the stenosis yesterday, there was a peak gradient of, what was it again, 30 with a mean of 16. Now technically the options you have is go for surgery and probably replace the valve, but the kid is only 3 years old and we would love to have immediately an adult size of mitral valve if possible. And what made us decide to go for balloon dilation was that the initial result was very good, with only mild stenosis and almost no regurgitation. So we figured that the mechanism of the stenosis was not as much outgrowth or something like that, but more like in rheumatic mitral valve disease, progressive healing with the stenosis. So we took the option of going for a mitral valve dilation just as a palliative procedure in order to defer the final surgical procedure. At the end, it's obvious that this kid will need another valve. So what we did in the meantime, please give the angios. In a small child, in my experience, just going with a stiff wire transatrially gives you insufficient stability. So what I was aiming for is put a long wire and then one way or the other fix it in the apex, and you'll see how we did it. So here's the transatrial puncture. Next run, where we confirm we're in the atrium. Next run, where we put a wire just as a safety line in order to push the whole thing through it. The septum was very thick. It was thick on echo, also on transesophageal echo, and also while puncturing. Next slide, next run is, so we did primarily balloon it with a 6 millimeter coronary balloon in order to get a big enough hole in the septum so we would be able to advance an 8 French sheet. Next slide. However, in order to do that, we first exchanged the coronary wire for a Amplatz ultra stiff 0.035 wire, and then we advanced the 8 French sheet into the left atrium, and that allowed us also to make an angio to have our references. You will be able to appreciate the enormous dilation of the left atrium, and especially in the profile you see the confirmation of what the echo already showed, that the mitral valve annulus actually is rather small. The trick then, and that's why you caught us in the first time you came to us, was find the hole, find the mitral valve, because it's rather narrow. Next run. So we first tried it with a vertebralis alongside the Amplatzer wire in the 8 French sheet. The Terimo wire could not find the hole, so I tried here with a prograde. It's much thinner and it It respects more the angle of the catheter we finally used was a cutoff pigtail, and you see at the end I find the hole in the mitral valve and leave the wire still looking, and here we are in the ventricle. Next run, we advance the prograde, the 2 French prograde, over the thin wire, and then we find the way out through the aorta in the ascending aorta, and that's where we exchange the microcatheter for a long BMW coronary wire. That was the safest thing to do. The disadvantage of those wires, however, is they are too thin. There's a mismatch and they kink like hell. You see over there at the top of the aortic arch that there is a kink, and it's very, very difficult to move any any catheters over that. So then we exchanged this wire first over, we went with a vertebralis, a 4 French soft vertebralis catheter, and we went through it with a long .035 exchange sterimo wire, which here you see was snared in the descending aorta and exteriorized through the aorta. At that point, now we have our rail, and so what we did was remove the fixating .035 Amplatzer who was in the pulmonary vein. We don't need it anymore. We came retrograde from the aorta with a stiff 5 French guiding sheet. Actually, the only thing that guiding sheet does is fix the exchange sterimo wire in the apex, so that we can push a little bit on that, and that allows us to much easier progress the 16 millimeter Tyshek balloon across the mitral valve. I mean, this was our first and only run, so you see how smooth it is. With this wire, it's very stable. It allows you to push on the wire, have sufficient stability in the apex so that things don't kink. And then finally we did balloon dilate over there, the mitral valve, so this is a 16 millimeter balloon. With echo we measured immediately then the result, and so the peak gradient went from, what was it again? From 20 to 12, and the mean gradient went from 12 to 7 millimeters of mercury without, so here you see the mitral stenosis after the procedure. Sorry, this was before or after? Before? Okay. He's looking at your screen. He's looking at your screen. Can you show the, and so this is what now? This was before, and you will now see the pictures after. So you see that the peak gradient went down to 11 millimeters peak and mean 7. We still are with the wire through it, but there is no regurg we can see at this point. I think this is a rather satisfactory result of this procedure. I think it will allow us most likely to win a couple of months, if not a year or two. And then finally it's obvious that this patient will need to go to surgery. But if we can put in immediately an adult size valve, it will be much appreciated. Sorry that we did already some of the things in advance, but we were waiting here, and we're with big sheets and a small kid, so that's why we progressed. Are there any questions at this point?
Yeah, thank you very much. Can you comment on the degree of pulmonary hypertension by echo?
By echo, there was a moderately severe pulmonary hypertension. There was a tricuspid regurgitation, which was estimated a pressure of 65, something like that. So the child he had pulmonary hypertension and became symptomatic because of mitral stenosis. Now the other thing I want to show you also, even in this small kid, the 3 meter Aanplatser exchange is borderline small. I mean, because if you show me the hands, here you see the arterial side. We are just catching on the pterymo wire, and this is rather big. I mean, one option, so it goes all the way into the left ventricular apex. We use the delivery sheet. It's typically what the coronary people use, the 5 French, which is rather stiff, and that the only thing it needs to do is be stiff and go all the way to the end, to the apex, to fix that point over there. However, because it's so long, we have little distance left, and so as you can see right now, I want to remove the tie check, but we already did cut off over here the end over here. We don't need it in any way, and the pterymo wire is already somewhere here. In order not to damage the mitral valve or the aortic valve pulling the things out, I have to push it out with tricks like this. And so,
Dietmar has a comment for you before you proceed.
Very nice approach, but stop. I would dilate the intra-atrial septum with a 60 millimeter low pressure tie check. And then you have a hole of 8 millimeter, and you have an additional wonderful effect on the pulmonary hypertension, left atrial hypertension, but you have...
Oh. Sorry, I didn't hear the comment. It was a little bit too soft. Can you repeat it?
No, you have done. I would, on the way back, I would have dilated the intra-atrial septum to let a hole of 6-8 millimeter. When you are dilated this intra-atrial septum with a 60 millimeter balloon, you will have a hole of 3 to 6, from 6 to 8 millimeter, and that would be very effective for the congestive symptomatic patient, in addition to the dilated valve. So I do it in this way.
And do that with a 16 millimeter balloon?
Yes, but you will have later on maybe 6 or 8 millimeter hole, not more. That I would do.
Okay, it's a good suggestion.
I have done.
Yeah. All right, do you have left atrial pressure tracing to show us?
Just a second.
And did you have it before?
No, we were too busy. But I must admit that when I do interventions, I behave like a surgeon. I measure only what is necessary, and I do and go fast what I need to do. Here we have the pressure. Bjorn, kun je even hier tonen? So there is still a mean pressure of 23. Can you show that up there? This is the left atrial pressure. It was estimated to be 30 millimeters at the beginning of the procedure. Now it is 23. Down below. Toon ik even, zet eens op 40.
So maybe Dietmar is correct in that a small septostomy will provide symptomatic relief also.
Might be, yeah. We still can do that.
Any thoughts? Other comments from the audience? Shiva Kumar. Kevin.
Yeah, Oliver made the suggestion, and I've seen it with cases as well, when you have these neonatal mitral valve or early infancy mitral valve repairs, the surgeons put a lot of material and pledgets and a band on top of the mitral, and you can get good benefit on a redo surgery with just resecting that tissue.
Yeah,
it's like a supervalve mitral ridge practically.
Right.
And it looked like that on echo.
See that on the echo. The leaflets look thin, and there's a lot of ring in the annulus. Yes, from our audience. We have 2 comments.
In some of the congenital mitral stenosis, when we do this procedure, at the beginning the left atrial pressure will be high and the transmitral gradient on echo will be quite high. But the moment we do the dilatation, probably half of the blood is decompressed by the atrial septum itself. So our reduction in the gradient that we get on the echo is not truly a reflector of success of the procedure. Part of it is getting decompressed through the atrial septum. So we need to turn the transesophageal, look at how torrential is the flow from the LA to the RA to decide about whether the gradients are really significant reduction.
Okay.
Thank you. And in the back, we have a question or comment.
Yes, hi, a comment. Sharon Borg from Israel. It's quite a small annulus, very thick cords, and it looks like the stenosis will probably recur pretty quickly. I wonder if anyone would consider putting a melody valve in this mitral position, and then we could work on it over the next few years and give the kid a more long-lasting, hopefully, result?
I think that is an option that can be debated. I must say that I was a little bit impressed by what Kevin described also as the annulus, which looked a little bit smallish. Now I think in the long run, this kid will get a surgical mitral valve in any way, and I would say probably the next best shot will be put in a surgical biological valve, and when that, with a big annulus, and when that valve deteriorates, put another valve in valve, and maybe valve in valve in valve, and go on until it doesn't work. I mean, until it's no more orifice, something like that. That's what I think would be a good option. And that way, it had one neonatal operation, one operation probably next year or the year thereafter, and then a long period as a child without a metallic valve. That's probably what we would anticipate in this child.
Okay, Jackie?
Just that it would be important to also measure the left ventricular end diastolic pressure, because after ballooning you may have a much higher EDP and then maybe even a better gradient that you want to report. The other comment was on the need of doing a veno-atrial loop for mitral valve balloon dilations. And of course, it gives you a lot more stability, but the big risk is that you can tear the mitral valve leaflet when you're maneuvering the wire, and I saw how careful you were to keep that loop in the left ventricle. Because I do remember in Boston, we had a patient, it wasn't actually mitral dilation, it was an aortic dilation, but the wire ended up tearing the leaflet of the mitral valve. So it's very, very tricky in an infant when you're doing those loops, so there is that risk. And how much do you need that? And in the Boston experience, we were not doing those loops with, into the artery.
Thank you.
I would say
all very good points.
say point taken, but then it is also the catheter. I mean, the guiding sheet. We did put retrogradely in the aorta into the apex. That gives a lot of stability, and that will impede the balloon, the wire to tear the mitral valve. Also, without that catheter, for instance, it would be difficult, as you say, or it might be dangerous that your wire gets caught in the anterior mitral leaflet and that you tear it apart while removing the wire, or even get stuck in such a way that you need the surgeon to go and get it. Over here, we'll remove the wire, and you'll see it is a rather straightforward procedure with the guiding sheet over there. Do you want me to do that?
Yeah, I think we'll have you remove the wire, and then we're going to proceed to San Donato for continuing their case. Thank you.